One day I sat with him and I said, "Sir, I'm sorry, but we've given you every single thing the book has to offer. There's nothing more we can give you." And he just smiled and he said, "All right, doc, so I'll see you back when you want to see me back." And I said, "I'll see you in 3 months because I don't think, in my mind, I'm saying you're not going to be here." And he said, "Doc, I'll see you in 1 month." And I said, "All right, sir." He came back in a month, he was still alive, and he actually had gained weight and his blood count was looking better. Suffice it to say that for the next 9 months, that man just kept coming back, and every single time he came back, he was stronger. His blood count was better. All his labs were improving to the point where eventually I just had to give him a 6-month appointment because he was just basically. And so that began to cement in my mind that there was more out there.
Welcome to Innovation Beyond the Chart. Today we meet Dr. Andre Williams, an integrative oncologist practicing in Montego Bay, Jamaica, whose story began with frustration over limited treatment options in public hospitals and has grown into a practice that blends the best in conventional and holistic medicine. Trained as a hematologist oncologist, Dr. Williams made a series of bold moves, from serving as one of just 2 oncologists on Jamaica's western side, to leaving a stable hospital job, to starting his own clinic, Teshuva Wellness. Driven by moments where standard protocols fell short, Dr. Williams sought new ways to care for patients by attending global workshops. In this episode, we look at what happens when the system's rules don't fit real lives. You'll hear Dr. Williams's field-tested solutions for adapting care to local resources, developing practical workflows for both small teams and growing practices, building trust as the foundation of patient referrals, and hiring for character while upskilling for operational needs. For healthcare leaders navigating resource gaps, shifting workflows, and culture building in an independent practice, this conversation offers clear lessons about how to find your bearings when the rules change, how to design systems that serve both staff and patient, and why people-first care is the anchor for true innovation.
Dr. Andre Williams, a real pleasure having you on the podcast.
Yes.
We had quite a bit of technical difficulties trying to get it started, so I'm sure it's going to be a good one. All right. So could you tell us a little bit about yourself, about your journey, and what brought you to where you are today?
Yeah, I mean, I'm a medical doctor by training. I'm an integrative oncologist. But that's a fancy word for what happens when you don't realize that life is sending in a direction. And then all of a sudden you're there and you're like, well, I need to have a name for what I do. So actually, you and I worked together at University Hospital. So
Yes, sir.
Many years. No, many years ago.
Even though the great service.
Yeah, so we worked together years ago in different settings. At one point, I was a resident, you were the intern, then you were working in ophthalmology, and I was working in hematology. So we both went to medical school. I came out and did postgraduate in hematology and oncology. And the aim was really for me to continue in that vein as an oncologist, practicing the usual stuff, chemotherapy, radiation, etc. I moved from Kingston to Montego Bay, from one end of the island of Jamaica to the other.
Yeah.
And the aim was that I was going to be one of 2 oncologists that side of the island and provide all of the international standards that we were taught to use for the patients there. But the interesting thing that happened was, 2 things happened. One, for every 20 patients I saw, only maybe 4 of them would agree to take in chemotherapy or radiation. And then we know that despite all our best efforts, not all 4 of those would do well.
Yeah.
So what was happening after about 2 years, I started to feel very disillusioned with the whole process. And started getting desperate to find what else was out there to make a difference for my patients and beyond. And fortunately for me, I was selected for an award from the American Society of Clinical Oncology. And as a part of that award, my work in a developing country was recognized, but I got also to meet at a conference in Chicago with doctors from other third world countries around the world. And we kind of exchanged ideas, and I started to realize that two things. One, chemotherapy and radiation, though they have been the gold standard for years, because of variations in the resource availability in different countries, we as doctors have had to get a little bit more innovative with adjusting the guidelines to suit our reality, and sometimes even finding things to come alongside the treatments. So coming out of that experience, I started to explore even more. And so over the past maybe 7 years now, 8 years, I've been going to workshops around the world and training with different doctors and learning how to use complementary strategies to help my patients with cancer, but also in some cases, how to use these strategies on their own without chemotherapy and radiation to very good effects. If you had asked me 10 years ago if I would be where I am now, I would have laughed you out of the room. But life played out that way, and this is where I am right now.
Okay. You said you were working, when you moved to the other side of the island, was it in a public setting?
Yeah.
How was that
Public healthcare.
experience?
It was tough. There was a large fluctuation in which drugs were available at any given time. You'd have a patient who would treat a lot of breast cancer patients. And depending on the time of the year when the patient came in, they might be able to access the drugs they needed or they might not. And so you found yourself having to make substitutions not based on any clear rational background, but just raw availability of drugs, which is not the best way to do it.
So just a timeline, you moved to Cornwall region.
Yeah.
How long ago? And then how long ago did you move to integrative oncology?
Yeah, so I finished postgraduate training at UWI December 2012. I started at Cornwall January 2013. And around about 2016 is when I got selected for the award. And that was a pivotal moment. The truth is, shortly after winning the award, I actually resigned my job at Cornwall and went full-time into private practice, which wasn't a smart move at the time because I didn't have much savings. I didn't have much of a backup plan. I didn't have an extra job somewhere, so I had to figure out how to make my private practice work. But because my patients started to get benefits from some of the complementary strategies, the word started to spread and it evolved beyond just cancer. People started coming to see me for other illnesses, autoimmune illnesses, chronic pain, that kind of a thing. And so it sustained and grew the practice. And now I have an integrative practice all around.
Yeah. So it sounds like you've made a number of dramatic shifts. Moving all the way clear across the island to going from a public hospital to private practice.
Yes.
That's much of a backup plan. And then you not only did that, but then you reimagined and went further out beyond traditional, what we consider traditional approach to medical care into more complementary services. So you could take us back, because there must have been a trigger for all of this, right? You could take us back to last year in the hospital. Is there any specific story or specific day that made you realize that the current model wasn't working? Who was there with you? Who did you speak with?
Yeah.
What were the circumstances?
I mean, I think it's just necessity becoming the mother of invention, really. What was happening was, truthfully, because of our innovation at Cornwall Regional, I put it that way, what was happening was patients were taking the opportunity to come from other regions in the island to Cornwall, because the word on the street was you could get better. Let's not use the word better, but you could get innovative care at Cornwall, especially because the other major hospitals were backing up in terms of their waiting time. And so what happened was really our resources began to be outpaced by the demand. And as I mentioned, the ratios didn't really change because you'd have patients coming from other regions, and when you explain to them that they need chemo and radiation, they would still have this kind of skeptical look. And then, of course, one of the pivotal moments, you spoke about pivotal, I remember distinctly having a stage 4 Hodgkin's lymphoma patient, and we had given him all the correct chemo, according to the book, precisely according to international guidelines, and he was just not budging. He was just getting worse and worse. And one day I sat with him and I said, "Sir, I'm sorry, but we've given you every single thing the book has to offer. There's nothing more we can give you. And he just smiled and he said, all right, doc, so I'll see you back when you want to see me back. And I said, I'll see you in 3 months because I don't think, in my mind, I'm saying you're not going to be here. And he said, doc, I'll see you in 1 month. And I said, all right, sir. He came back in a month. He was still alive and he actually had gained weight and his blood count was looking better. Suffice it to say that for the next 9 months, that man just kept coming back, and every single time he came back, he was stronger. His blood count was better. All his labs were improving to the point where eventually I just had to give him a 6-month appointment because he was just basically. And so that began to cement in my mind that there was more out there. And the question now became, how do you responsibly bridge that gap between the one extreme and the next? So you have one extreme that says, okay, chemotherapy is the be-all and end-all of cancer treatment. You have the other polar opposite, which says we don't want anything to do with chemotherapy. We want all natural herbs, and if it's not natural, we're not going to take it. And I think the myth that's out there is that there's no credible information about anything other than chemotherapy and radiation, and that's not the truth. In the same breath, there are people who take this natural thing too far and believe that herbs can solve every problem. But somewhere there's a nice middle where someone like myself, who has been trained in both extremes, I have the ability to look at a patient holistically and say, okay, based on what I'm seeing here, you actually would be a better candidate for chemotherapy initially, along with some complementary strategies, because this cancer is very far advanced. Or in some cases, I could say the same thing in the opposite way, which is, because this cancer is so far advanced, I think it's best that you not try chemotherapy. Let's try to strengthen your body with some natural supplements first, and then consider options afterwards. I've been fortunate enough to get that exposure. I didn't plan for it, but it was just desperation. And now I'm able to look at a patient through different lenses.
Okay. You would have a network that would react to some of these decisions that you're making. So, for instance, from the move from that steady salary in government to practice, what was the reaction of the people around you who pushed back the hardest? How did your decisions land emotionally with them and I guess yourself?
Yeah, it wasn't easy. There's no doubt about that. My family members are very concerned, to say the least. And of course, walking to the hospital every day, I would constantly be stopped by different doctors telling me that I'm making a very unwise decision and I'm throwing away my life and so on and so forth. And that wasn't easy, because you're just trying to go and do your work, and you're just like, you're walking on the hallway to like a kind of ticker tape parade of people trying to intervene. I have a very supportive wife, Nisha, who is a registered nurse as well. And so she walked with me through that difficult time, and she kind of helped me to prop up the private office as well. So the rest of it is just God. There was no real plan. God just kind of made. I mean, I remember in the early days, we had no sign. We had no real phone number. We were upstairs in a little corner of another doctor's office. And literally, I remember people walking in and saying something just told them to come off the street and walk up these stairs, and they would get help. That was just a blessing. And over time, we started to figure out how to market and so on. I still don't think we've gotten it right, but we're doing something different. That's the truth. Is most of these things are word of mouth. Success breeds more success. And we've been fortunate to have lots of successes.
So I suspect then, how has this experience over this period of time changed your relationship to risk?
Yeah, that's a good question. The benefit for me was I went through medical school very young. And so when I came out of medical school, I was still very young. I started postgraduate at age 22, probably. So I was pretty young. So I've always been the youngster amongst my peers. And so intuitively, I wasn't that risk averse initially. I mean, when you start taking on the responsibility of caring for a wife and your extended family, then you start to be a little bit more careful. But I think because I've always been a curious person, scientists, I believe, always have to retain curiosity. I think what happens is that even when there's lots of risk, my curiosity outweighs the risk. So as a result of that, if I believe that there's an opportunity to help patients in a greater way by taking a specific risk, then even though it's risky and my heart is beating fast and I'm maybe losing sleep, I'm curious enough. I'm like, okay, but you could maybe help 100 patients versus 20. So it's probably worth it. And so far, it has been worth it. I mean, I've had times when I went on a trip to Seattle, had to pay for airfare, accommodation, plus the workshop training for a week. And that was in those early days as well. And I started looking at myself in the mirror like, are you crazy? But those tools and techniques that I learned in that 1 week are what have served me to this very day, and I've gotten better and better at them. So it was worth it.
Yeah. Okay. Do you find though, so you're integrating conventional and holistic medicine, all right? Do you find that there's a greater need or less need for diagnostic resources to be able to determine where that balance is for a particular patient?
It's an interesting question. I think as a society, we've become very imaging dependent. And I think as a result of that, the public in general has come to expect imaging for everything.
I remember.
Now, where we were trained, we were heavily trained in physical examination. It was drilled into us because we were trained under the British system. And you had to be able to pick certain signs up just by examining the patient. And again, because we were in a relatively resource-poor setting for training and for practice, we didn't have the luxury of MRI for everything. And I think even the US healthcare system now is starting to feel the brunt of that reality as well, which is it's expensive to run an imaging test for every single question that you have. So even before going into integrative medicine, I considered myself a clinician. And I believed in the ability to examine the patient and get the information and using imaging to confirm or give additional scope to the information that I'd already gathered from the history and physical exam. So I'm big on taking a good history, and that hasn't changed regardless of the approach I'm using. As I said, I mentioned that I've learned several other examination techniques, physical examination techniques that are also pretty powerful. And because of that, I'm less dependent on imaging to tell me what I need to know, because it takes time to get the wheels turning anyway.
Yeah.
And so even before I get the results back, I usually have a plan in mind of what I want to do for the patient.
Okay. So you'd say then that the need for the image, for the extra resources would be probably not necessarily by your specific practice, but because of how we were trained to use clinical acumen first.
Yeah.
Then this kind of practice
Yeah.
thrives in that environment.
Yeah.
That you can actually do a lot with just your hands and your ears.
Precisely.
Right. I remember a situation some years ago where one of our well-known consultants in the country was able to make a similar diagnosis, just talking to the patient and examining the patient, made a diagnosis. But as I said, we're all into imaging and stuff. So the patient decided to go overseas and spend huge sums of money. And a few months later, the same diagnosis was arrived at because the doctor was able to use an examination and history to make a diagnosis.
And you make a good point too, because what has also happened to me, I don't talk about this much, but part of the training that I do actually is treating sports injuries. And so I've been fortunate enough to treat several Olympic athletes over the period of time, because Jamaica is a track and field country. And because of the techniques that I had learned overseas, people started to hear about me. So instead of flying to Europe to be treated for injury, they just came down to Montego Bay. And I've had several occasions where the athletes who, the least that could thing happened to them, they run an MRI. And one of them came in, more than one, but this one in particular came in with an MRI result and said, hey, the doctor said, this is a problem, this is where you must treat. I said, well, I'm going to do my physical examination and then I'll tell you where I want to treat. And the person said, no, this is what the MRI shows, I need you to treat here. And I said, well, let's make a deal. Let me examine you first, then we decide. And of course, when I examined, the location of the injury was a good maybe 6-7 inches from where the MRI said it was. Because the MRI can only show disturbance of tissue, actually show the origin point of the injury. So I made a deal with the person, hey, let me treat you and you tell me how you feel. I treated them and say, all right, run through the paces. And of course, they felt the difference immediately. flew back to the States, and I told the doctors that, hey, I went down to Jamaica, the doctor treated here. They ran the MRI again. I said, oh my God, he was right. It's where we thought the injury was is not where it was. So,
Yeah.
so there are false negatives and false positives as well with imaging that you have to be aware of. And sometimes it forces you as a doctor to make a judgment call based on your clinical suspicion, you know?
Do you still have, I remember earlier you mentioned a situation where people were treated based on what medication was available. I suspect that the private is a little bit different, but do we still have those issues where even though there is the complementary medicine available, right, you still think this person needs chemo or some particular conventional modality? Have you found where that has impacted treatment, and what have you done to go around there?
Yeah, that's a complex question. I'll tackle it this way. I think I've been fortunate enough to retain a good working relationship with the doctors who do conventional medicine. And because of that, because we're both aware of the harsh realities of what we're dealing with within the island, what we've done is create an informal understanding amongst ourselves that we would try to help each other help the patient, if that makes sense. So, for example, if I see a patient who has come to see me specifically because they are afraid of getting chemotherapy or whatever the case may be, or I'll give you a better example. Just recently, a patient came to see me, didn't want to do radiation or chemotherapy for cervical cancer. The truth is, regardless of what I do for the patient to support them, they still need to have that treatment done. Because of the location of the cancer, it's ideal to have it. So negotiated with the patient, worked with them long enough until they felt physically and emotionally capable of doing the treatment. Sent them up to the hospital only to hear that the radiation machine had just broken down.
Oh, wow. Yeah.
So then the patient said, Doc, see, it's a sign. It's a sign that I'm not supposed to do it, which is not really the case. So what I ended up doing was making a quick call up to the hospital and say, hey, listen, this patient needs to be treated. I'm going to try and keep supporting them on the complementary side, but as soon as the machine is up, I need to get them in as a priority because, you know, they've been waiting for a while and so on. And so they gave me that luxury of giving me that phone call to say, yes, the machine is back up and the patient is scheduled to come in on X time. So I could talk her down off the ledge to say, hey, you can still go and access the resources. The doctors have still retained the original date. The machine is fine. And I'll check in with you each time you go up there to make sure you're okay. So we've had to get creative, but I think what you're asking is how the resources impact us. And the truth is that physical and medical resources are one thing, but as human resources is another.
Yeah, for sure.
And what I've learned is if once we can keep the morale and the working relationships good between our colleagues, usually we will collectively find a way to innovate our way through the challenges. And so far, that has been the case. Jamaicans are generally very creative.
Yeah.
So we found a way to innovate around most of the challenges we faced.
Do you have anything that stands out particularly in terms of innovative or interesting solutions? Naming names.
So yeah, there have been multiple. One of the first things I can say is that in that forum that I attended, the annual conference in Chicago in 2016, that was the first time that they were developing a steering committee to recognize that in resource-poor settings like the Caribbean, Sub-Saharan Africa, and some areas of the Middle East, the guidelines that they were recommending for chemotherapy and radiation and the workflows were really just not practical.
Yeah.
And coming out of that meeting, they started to form working groups in the different regions to develop modified guidelines for these regions, which are now referred to as harmonized guidelines. Very interesting. And and so one of the stories I like to tell is there's a drug that we used to use for patients who develop bony disease. It's a drug called zoledronic acid. And I, over the years, using it according to those guidelines before they had started to amend them, I always used to notice that one, it was prohibitively expensive. So we were supposed to give it every think it was every 3 weeks initially, 3 to 4 weeks. And what I often found was that one, patients couldn't afford to get it every 3 to 4 weeks. And also when I gave them every 3 to 4 weeks, they would get really bad side effects really quickly. So I made a unilateral decision that I was going to start giving it every 6 weeks. I was doing that for about 6 months to a year. All of my patients, I used to just say to them, hey, don't tell anybody, but we're just going to give this to you every 6 weeks. And I found that one, they could afford it better, but secondly, they took a much longer time to reach the point where they started getting side effects. And about a year or two after I made that decision, the guidelines came down from above to say, we've discovered that it's best to give this drug every 6 weeks instead. And to this day, that's how it's given. So that's a good example of forced innovation.
Yeah, for sure. You raise an interesting point in that a lot of the guidelines that are developed are not necessarily suited for our environment.
Yeah.
But there's the idea that you have to personalize the treatment to the patient, which is one way of dealing with it. But I think that there still needs to be work done on creating those kind of harmonized guidelines, as you said, to give better guidance to the doctors who are treating patients in these environments. And it goes, perhaps the reason that your patients were developing side effects faster on that recommended guidelines would have been socioeconomic factors, support factors, right? Nutrition.
Yeah.
So all of those things are things that need to be taken into consideration.
Yeah. Who is going to fund it though? That's always a challenge.
That's the thing. Who
and
these things.
Yeah, and as you know, I'm not a big conspiracy theorist. I don't think there's a need for it. So I'm not one of those people who goes around getting upset about this big pharma story. But the reality that we face is that a lot of studies are sponsored or funded by pharmaceutical companies. And as a business person, you're not going to fund something that's not necessarily going to benefit you. And that's really my approach. I mean, there are some things that definitely are very questionable that are done sometimes. But generally, my thought is the pharmaceutical companies in it to sell their products. They're in it to make a profit. And so I don't foresee them funding something that has an abstract benefit to society. So we need to start getting,
especially in smaller economies, when the benefit is in economies that are
precise, not going to make a difference. I just look at it at face value, and I do what I can for each patient that I see. So far, that seems to be working out nicely, and hopefully at some point I'll be able to get a wider platform to be able to influence on a larger scale some of the trends that I see happening in our setting.
Yeah. So you're building a new facility, right? And a team means that you have to add another dimension into your expertise, right? You're looking at logistics, budget, staff, space, interior decoration.
Yeah.
The uncertainty, who will show up? How do you reach them? You spoke about word of mouth, but I'm aware that you've had a journey from the beginning of the business to what becomes a coherent story. So even that is an expertise. How do you develop a coherent story around a business? You talk about the ideas and then the operations and how everything comes together.
Yeah.
Right? Let's look at, you guys have an interesting decor, right? Let's look at how you came about, your space, right?
Yeah.
How you design your space, and see if you could tie that to your vision, your ideas, your strategy. What were your intentions for your patients, and how did that translate into space?
Yeah, that's a good question. Nisha and I work together. We're husband and wife. And the business is called Teshuva Wellness. So Teshuva means to return to God, but it also means to return to your best self. And the whole idea was that we wanted the experience when somebody visits the office in Montego Bay to be one in which as soon as you walk through the door, you feel like you're returning to your best self. So the design of the facility, we used very specific insulation in the walls, non-allergenic substances, low sheen paint, that kind of a thing. We used colors that were muted and meant to calm the nervous system. And we designed the decor and the workflow of the building in such a way that when people walked in, they wouldn't feel like they're in a doctor's office, but rather more like they're in a spa. And so our whole aim was that people would actually step into a different world when they walked into our office. And we weren't just saying that because some people say it and it becomes a yoga facility, but we wanted it to be a coherent blend between medical professionalism and at the same time understanding that this was somewhere that was meant to make you relax. And so far, we've managed to achieve that ethos. We use a lot of natural sunlight as well. Our contractor was very upset. The contractor was saying that it was the worst thing for the heating, the cooling bill, and so on. He wanted to block it all off, and we said no. And I also designed my doctor's office unnecessarily large in terms of the use of the space because I wanted people to step in and feel like they were in their living room with comfortable furniture. And, it has worked because we've gotten multiple comments about how relaxing the place is. And when people walk into my office and the sunlight hits them, they smile nicely. Immediately, everybody's nervous system calms down. The other thing is that we've deliberately positioned ourselves in terms of our marketing very carefully as well. Because the assumption usually is that once somebody goes into a naturopathic approach to medicine, that they're pushing herbs and they're pushing all natural. And so it has been difficult to keep a consistent message going in terms of what we're about. And the truth is we've constantly been evolving and improving. So our message and our service offerings have always been evolving as well. I don't think we've really gotten it right. We've failed often. We've picked ourselves up quickly. We've had very good team members over the years who have been very gentle and caring to the patients, so that has helped. And then, when it's a husband and wife team, there's no escaping the responsibility. You just have to make it work somehow. So otherwise you don't have any food. So, I really don't think that it has, it's just been repeated experiences and learning from them. It's been the grace of God helping us to not make devastating mistakes. So most of the ones we've made, we've been able to recover from. And I don't think there's any perfect way to run a business. You're always going to make mistakes, even when you have all the degrees and training necessary. I think the key is to not make the same mistake over and over. So far, so good.
Yeah. You laid out two interesting threads I want to put there. One would be any mistakes that stood out to you as you were talking, anything that crossed your mind. And also when you would have known that what your staffing model or your team structure was going to be like.
Yeah.
All right, we could talk about the more interesting one for
the mistakes. I think the biggest mistake that we made was I don't think we could have foreseen it, but we learned from it, which is that we applied for a grant to do leasehold improvements and outfit the office, buy equipment and so on. And I think we simultaneously applied for the grant and also put in an offer for the space we wanted. And what ended up happening was when we needed to present financial statements, it wasn't a grant, it was a grant/loan. And when we needed to present financial statements, the accounting firm who we were assigned to said, hey, listen, it's tax time, we can't take on any new firms right now. So you're going to have to wait until we've submitted everybody's tax returns. But we had already entered into the lease, and they gave us 3 months to complete the leasehold improvement. So it ended up with us not being able to build out in the 3 months, and ended up taking maybe 6 months total to do the build out, which meant that we started off the building with 3 months rent in the back. Which was a constant thing trailing for a while. So things like those, you kind of wish you could have done differently, but then the good thing is eventually we became profitable and we were able to clear the backlog and move forward. So yeah, you don't foresee everything, but you learn. As it relates to team members, I think our policy has generally been to hire based on character primarily. We try our best during the interview to get a feel for what this person will bring to the team in terms of their personality and also their values. and how they will match the culture that we're trying to achieve for ourselves as well as for the patients. And so we've emphasized that over the years, and we have actually put a preference for team members who have the desired character traits over sometimes a degree or a master's or PhD. And it has its pros and cons. Had some very good team members over the years, and we've developed a very good culture. What tends to happen though is sometimes when the business starts to grow and the level of responsibility that a particular team member may have changes, sometimes the lack of professional certification starts to be exposed, and then the person is just genuinely unable to function at that level because they've not been trained into that capacity. So we've tried our best to upskill our team members as best as we can in-house and also externally where possible. It's something that's still a work in progress, and we're still learning how to do it well.
I think that the culture part is actually pretty important. When you start a business, right, building that culture, whether you realize it or not, there's always going to be a culture being built. And a lot of times we don't build that culture intentionally, right? We just allow something to evolve, and then when we look, we don't actually recognize our business. Right?
Yes.
It's not us. So that's actually important.
Yeah.
The other thing that you mentioned, which I found interesting, was that you actually looking for persons that could add to the team, right? So there's one school of thought where you're looking for persons that fit in the culture, right? But there's another school of thought where you're looking for persons that not only fit in the culture but can extend it in the direction that you're looking for. So maybe fill in some gaps, synergize, transform the culture in a direction. Looking for that specific, how that person adds to the culture, I think is quite an important thing. Yes, I was going to ask about how you've managed to thread that needle between hiring for culture and then when that person hits the ceiling, how you address it. It seems like you're still trying to figure that out.
Yeah. So the truth is that we like to cross-train our staff. So we create a culture where, to the best of one's ability, one should be able to. You're functioning, for example, as, let's say, the attendant for the office. We still teach you how to answer the phone using the script, and how to take a message, how to greet somebody at the door, how to greet them, and how to say goodbye when they're leaving, how to greet somebody in the waiting room when you walk in past, that kind of a thing. But then again, when you start to, as you know, there comes a time when you need to implement systems, like actual systems. And so that if they're computerized systems, automated systems, then what that's going to require eventually is some degree of computer literacy.
Yeah.
And so, of course, that takes time to train somebody in. And so that's where it can get challenging at times when you're now upskilling the person to say, hey, we need you to start entering an invoice or checking for a payment or putting an appointment in the calendar. And that tends to highlight the inherent weaknesses that the person may have, and then it can be very awkward. And so you have to make a judgment call for the business, which ultimately can affect the team culture. So it is a work in progress. And ideally, you'd be able to constantly have ongoing certification for all staff members. But it's still a small business. That's also a consideration for financial input and that kind of a thing. Yeah. The truth is, now that I've been doing this for 9 years now since I left the hospital, when you first jump into it, you feel like you're in open sea with no savior in sight. But over the past 9 years, you realize that challenges are cyclical.
Yeah.
And the same challenges you're going to face just manifest in different ways. But guess what? Over the period of time, you have grown. And so your capacity to respond to them has improved. So after a while, you start to expect challenges and you just trust that you have the ability to respond.
When did you stop feeling like you were out at sea without a or you used to have that anything?
I mean, I think my outlook has changed. I've become more comfortable in my own skin. I think it's because I've hit what I thought was rock bottom multiple times. You realize that you're still here, and as a matter of fact, most times you bounce right back up or bounce beyond where you were before. You start to realize that rock bottom is not that bad. And you don't want to stay there, obviously, but if something happens and you end up there,
And it's not the end of the world.
exactly. It's
But it
temporary.
sucks.
It's temporary, and you try your best to learn quickly and get back up.
Yeah. So what do you guys track in your organization? We speak about, when you mentioned scripts,
Yeah.
right? I was thinking about the distance or the dichotomy between what people consider innovation and what scripts means or seems to imply. I know we're also going to talk about another thing that people instinctively think is not in line with innovation, which is measurement and numbers. But what do you guys track? And then we'll talk about how that enables you to innovate.
Yeah. So we're still working through that. So I wouldn't say our KPIs are set in stone, closely adhered to. But generally, what's most important to us right now is leads, of course, and an average dollar purchase. And we are actively trying to work on ways to increase our repeat customer transactions. Because leads generally, with the best of intentions, leads still come primarily by word of mouth and referrals. And so it's difficult to amplify that variable on your own. We've tried, and it works to some degree. Social media helps.
Yeah.
But so it's easier then to try and look at your database and say, okay, how can I start using the CRM to keep the conversation going with the patients who already exist?
Yeah.
And so right now we're actively looking at strengthening the database, developing more of a segmentation so that we're not sending messages that are too general when really we should be targeting a specific segment of our database. I believe that with that, we'll still be able to maintain the word of mouth for leads, but then we'll be able to increase our repeat transactions, hopefully, and be able to track that. I get in some static.
Yeah. It's just started raining.
Oh, all right, that's
Yeah.
fine then. That's okay.
We're hearing it.
That's fine.
Rain is good, eh?
Yeah, it's blessings. Okay, go ahead.
So let me know if you're not hearing me properly.
No, I hear you
Alright.
good, just hearing the ring.
I think another good point you made is two things, right? It seems in healthcare, word of mouth and patient referrals and referrals from other doctors we all seem to be interested in leveraging social media as much as possible and all of these TikToks and all of these things, but
Yeah.
healthcare is predominantly a trust-based endeavor, right?
Precisely.
You go to the people that your people trust.
Precisely. So
And
I
then
had a
go
patient
ahead.
come to see me the other day, and my jaw dropped open because she said to me, I came to see you only because one of my best friends, you treated him something like 10 years ago. And I was there. You didn't know me then, but I was his best friend for all of that period of time. I watched as he was treated by you, and I watched his success over the past 10 years. And I look at him today, he's a totally improved man and so on. And from that time, I told myself if I ever needed a doctor, I'd come to see you.
Yeah.
Now, here's the thing. I don't know what you do. I don't know anything about you. I don't even know what your business is about. But I'm sick. Actually, it was her mother. Her mother was sick. And she just went to her friend and said, hey, what's the name of that doctor that treated you 10 years ago? He told her, and she just booked the appointment. So it's like that. So no matter how I put out on social media, hey, I did this fancy thing, it might not have meant anything to her, but because I treated her best friend, she just dropped everything and brought her mom to see me.
So I think that the lesson there is that we really should stop chasing the likes and the shares, but you can engage your patients, the patients in front of you, as well as the thing that you're doing in terms of keeping a conversation going with existing patients.
Yeah.
Your existing patients are going to be more valuable and more
Yeah.
help to build a business.
So I think what I've done though is lately I've been trying my best to do like just a quick post every day. And all I'm really doing in most cases, and I put it on my personal brand, a personal account, meaning me as a person rather than me as a business. And what I basically do is just talk like I'm talking with you today, talk for 3 minutes. Like the other day, I just posted about the fact that, I think we need to start practicing more root-based medicine where we try to find the root cause of things. And, you kind of get people thinking. And I think the response that I've been getting just from those little posts, it's good to see you talking more on social media. You're, we like when you talk about these things because nobody's talking about it. And I'm like, I don't know what you're talking about. I just turned on the phone and started chatting. But I think you made a good point, which is social media is, at the end of the day, social, right? And when I was training with a business coach once, and he said to me, the concept of people need to first like you. Then after they like you, they'll trust you. And then after they trust you, they'll buy from you. And of course, there are some people that abuse that concept. But the truth is, unless you are visible in the space, even if you don't have a direct one-to-one relation between you posting 100 posts and getting 100 leads, I think it's still important for you to be visible and have a voice in the space that you're trying to impact, just so people can know who you are, so to speak. So I'm trying to do that.
So I guess you're using it to build a little bit of trust. When people see your face, they hear your voice, you're also delivering value. All right?
Yeah, of course.
Yeah.
I wonder if it's backfiring though, because now I'm starting to walk in the supermarket and I'm getting these weird looks.
I think it's good to be out there educating the public.
I think they're probably saying, do I know this guy? Or isn't he? Anyway, who cares? I've never really cared much about image and what people think about me. I still, to a certain degree, obviously you want to present yourself well, but it's in the line of work that I do, it's difficult for you to take things too seriously. I remember hearing some of the rumors that people had circulated about my practice at one point, and initially it stung, and then over the years they're like, oh, really? I remember one time somebody saying that they heard that I only charge in US currency. And I said, that's so not true. But then I started, after a time, what happened was I started to treat more patients from overseas. So I did have to charge in US anyway. So I just take it as a step in. When people throw stuff at me, I just kind of climb on the stones and climb further up. Or I see it as an indication of where God wants to bless me next. And I just say, okay, good. US, here I come.
Yeah. So that's the other that came out then. So it's important to build the trust, right? And you can build the trust by being visible, by being out there, letting your voice be heard. But you also have to nurture your existing base and keep the conversation going.
Yeah.
Yeah. I think, definitely those both are important. Both are important.
I want to just say one last thing before. I wanted to wax philosophical for a bit because over the years, what I've found is a very interesting phenomenon, and I call it the box phenomenon, for want of a better word. And the box phenomenon simply states that I think as medical professionals, we are constantly training our mind to think within a box. Meaning a patient comes to see you, the purpose of they walk into the office, the first thing you're doing is you're looking at them and making an assessment. But that assessment is within the box of how you were trained. Then you ask questions to elicit symptoms and signs or symptoms based on how we were trained. Then you examine to find signs based on how you were trained. And ultimately, what you're trying to do is to make all of these things mean something within a box, which is great for a clinician if the patient's complaints fit within a box. Yeah. What my experience and journey has taught me is that more often than not, patients don't come fitting neatly within a box. Unless you're super specialized and you're being referred to by another person who has already identified that this is something that fits into your specialty, then what tends to happen is you'll often have outliers who will have what I call wastebasket illnesses. So, for example, fibromyalgia. What do you do with that?
Yeah.
And so I believe personally that there's no need for polar animosity between conventional and so-called naturopathic practitioners, because the truth is there are times when people just don't fit neatly into a box. And that's where I find myself feeling most excited about exploring those gray areas and finding what are the commonalities between all these patients, because we are made by the same manufacturer. Yeah. And so there must be, even if we have not yet found the answer to these diseases, there must be an answer somewhere. What I find as medical professionals, conventional, we try to say, you don't fit within the box, so I don't know what to do with you. And so we inherently feel helpless. And so I've learned how to step past that helpless feeling and probe a little bit. And over time, if you listen to the patients long enough, you start to notice patterns. So every time somebody comes in and complains of this, I say, hey, I ask them a different question than I'd usually ask. And I start to realize, hey, all of these people have had this happen to them in the past. I wonder if there's a pattern. And this is the true nature of how medical science was supposed to be. But like I said earlier, I think we've lost that curiosity and that willingness to push beyond what we've previously known.
Why do you think that is?
I think it's twofold. I think it's an element of pride. I think we've become very proud of what we know, and we've equated what we know with our ability. They're two different things. And the second thing is the legal side of it, where we're so concerned about being sued that we want to make sure we get it right, and we don't want to take on any unnecessary liability. So I think it's twofold. I think the truth is, if we're honest with ourselves, we pride ourselves. Maybe pride is a strong word, but we feel confident in our ability to say, okay, this person has chest pain. I can find out the cause of their chest pain. But then when you realize it's not a heart attack, it's not GERD, it's not pulmonary embolism, and you go through all the list and they still have the chest pain, it does something to you if you're not careful, takes you down a notch. You realize, I don't know why this person has chest pain, and I've gone through all the 17 causes that I learned.
But what I was asking, really pride and not necessarily, but I think you rephrased it as we're confident in the system.
Exactly.
Right? And the system gives us comfort and security.
Precisely.
Because I think deep down, we should know that the human body is not something you can necessarily
No.
Or the human condition isn't something you can necessarily, more than the body is about social, spiritual, everything. All of that is not something you can necessarily put in a box or put a finger on. So I think having those frameworks gives us some kind of security that this is a road that others have traveled before. I should be safe.
Yeah, exactly.
Traveling the road. And
so here's how it plays out in the extreme. I'll give an extreme example with a patient who came to see me with stage 3 non-Hodgkin's lymphoma. Still alive to this day. It's been 5 years now. So I'll give you the spoiler alert. He's still alive. And when I met with him, his challenge was that he was enrolled to do his chemotherapy. But like we discussed earlier, there was a delay in there was none of the chemotherapy he needed available. And I think there was some delay with his scheduling of his appointment. So he would not be able to be enrolled into the chemotherapy suite until 3 weeks' time. So out of that, he came to see me. He said, hey, I don't feel like I have 3 weeks to sit and wait. Can you help me in the meantime? And in the course of examining him, I realized that he was a farmer. And when I tested him, I realized his body was overflowing with a particular pesticide, which I won't name because my YouTube videos keep getting taken down lately. And so I said, all right, here's what we'll do. I'll work with you. He had a massive, like, grapefruit-sized mass in his groin. And I said, I'll work with you for the 3 weeks and help to get you nice and clean so that when you go for the chemotherapy, you'll be in a better physical state to tolerate it. And it just so happens that at the end of the 3 weeks after working with him, the grapefruit-sized mass disappeared. So I felt good, he felt good. And in his mind, he thought, okay, so I don't have to do chemotherapy anymore. And I said, actually, no. your responsibility is to go to the hospital, have them reassess you, and have them make a determination on what they want to do, because I'm just working alongside. It just so happened that I got a nasty letter from the hospital saying that they realize that I have been involved in the management of their patients and without their knowledge, and they want me to list everything that I've done for the patients, and that was very discouraging. Yeah, so it goes back to that concept of the comfort zone. So even in the face of a patient who has quite clearly gotten better, the comfort zone has been disrupted, and you're now faced to make a call that you wouldn't normally have to make, which is, do I still give them the chemo even though they're better? And
Exactly,
so instead of reacting with curiosity, you react with anger. Anyway,
So it becomes a kind of defensive mechanism.
there you go.
Defending
There
the
you go,
first
status
person.
quo.
Yeah, the status quo.
Yeah.
Yeah, so we're wrapping up, but I do have some further probing questions. Do you have practical solutions? There are 4 practical solutions that you use on a daily basis, on a regular basis, that you could give listeners that they could try to deploy in their settings. Anything any advice that you'd like to give?
Yeah, I think the first thing is to always stay curious. You have to always be curious about everything. And I think even in today's world now, where artificial intelligence has changed access to information, and it has also changed the authenticity of information in some cases, I think we always have to remain curious. I think the moment that we as scientists start to lose that element of being able to question something and evaluate it properly, we're going to be in trouble. And I think also the second thing would be not just to be curious, but also to remain open-minded. I think culturally and otherwise, our world has become very polarized, and some of it is deliberate. There's a deliberate attempt to segment people into one pole or the other pole. So conservative versus liberal, black versus white, and so on. And we can't afford for that to happen in the field of medicine. I think the third thing also for healthcare professionals is, at the end of the day, everything you do has to boil back down to how this will help the patient. And if what you're recommending is not actually going to help the patient, then you may want to think about it again. So if you're ordering a test just because it's the next test on the workflow, but then you know the patient is not going to do it, and you may never see that patient again, then you have to kind of question, okay, what is most beneficial here? Am I just going to order the test, or am I going to see what I can do to help? And then the fourth thing is I think the fourth thing also is to not think too highly of yourself. That's one of my like stabilizing forces. My wife does really good at keeping me humble. Yeah,
You can just
so at the end of the day, you're a person, right? And I think when people tend to burn out is when they start to elevate when we start to elevate what we do above who we are. And at the end of the day, I'm Andre who practices medicine. I'm not Dr. Andre who is also a husband or a son or a brother. So I try my best to start off with being Andre first, and then when necessary, I become Dr. Andre when that's necessary. And believe me, I'm quick to take off that title because it comes with so much additional responsibility sometimes. I don't mind that switch. Yeah, I think those are my 4 core things.
I remember at the end of the day, the symbolic removal of the stethoscope.
Yes, sir.
Around neck was a thing.
Yes, sir. Yes, sir. Yes, sir. Definitely.
So you mentioned curiosity, right? One important thing, and I think it came out to your discussion, was you stay curious about the world, about the patient, but you also stay curious about your business, the thing that you're building, right? Because it's evolving. You're building it, but it's also evolving within an environment that is new to you, right? You're in Mobe, you're building this new business. You're also learning about the business, just like you learn about a child growing up, right? So staying curious about the business and learning the essence of the business as it expresses itself it's your business, but you don't know everything about it.
No, not even half.
You're learning it as you go along as well.
Yeah.
So where can our find you? You spoke about your YouTube and all those
Yeah.
other fancy things you're doing. So where can we
Yeah.
find you?
So YouTube, I'm Wellness Doc Jamaica, WELLNESS, that's wellness, and DOCJAMAICA, Wellness Doc Jamaica. That's my personal brand. My business is Teshuva Wellness, TESHUVA Wellness. And once you type that into Google right now, you're gonna find us anywhere: Facebook, Instagram, just on the internet itself. I want to put a little plug in because for the past 4 months, I've been working on a digital course. You spoke about the business evolving, and I've realized people don't necessarily
Yes.
like to visit doctors' offices, and to a greater extent, they're not visiting even remote consultations as much because everybody now wants to be able to have video on demand. So I'm just about to launch a very powerful course called the 15-minute cancer decision. And that course is going to help patients who've just been diagnosed distill all of the information that they have been bombarded with down to really a short decision-making algorithm that helps them to get clarity on where they need to go, which advice they need to adhere to, and what treatment options actually suit them as a patient. Because too many people have reached out to me from first world countries saying that the doctor didn't take the time to really explain to them what stage means, what biopsy means, and there's nowhere where they can go to get harmonized information that pulls everything together. So I'm gonna launch that in a few days. So by the time this is released, you can put a link somewhere in the show notes, and your listeners can be able to follow up on that if they need to. And it's where the business is going as well. We're moving toward digital content, on-demand digital content that people can use to educate themselves long before interacting with me as a doctor.
Very
Yeah.
exciting stuff. Exciting stuff.
Yeah. I'm learning how to promote. I'm learning how to promote my stuff. It doesn't come naturally, but I'm getting better at it.
We and me both. All right. Thanks, Andre. Thanks for your time.
No
It's been
problem, man.
an amazing conversation.
Here are the key takeaways from that wonderful conversation with Dr. Williams. The key takeaways and reflections, my reflections. First, Dr. Williams' story is a clear reminder that adapting guidelines for local realities for your patients is essential. He described how standard chemotherapy protocols sometimes lead to worse outcomes or weren't even possible due to cost and access. By adjusting drug intervals and leaning into creative problem solving, he and his colleagues actually found ways to deliver better care within the limits of what was available. For independent healthcare leaders, this is a nudge to critically assess whether imported standards fit your patient population or whether it's time to modify workflows for your context. Second, the importance of clinical skills and patient-centered listening came through again and again. Dr. Williams emphasized that in resource-limited environments, strong physical examination skills and careful listening can actually reveal diagnoses that technology might miss or access might delay. He gave examples where even Olympic athletes benefited from his hands-on approach, highlighting how investing in those foundational skills that we were all trained with and relationships can be more effective than simply relying on new equipment. Third, trust and teamwork emerged as hidden backbones of innovative care. Whether building informal networks with other physicians to navigate broken systems, broken machines, or sustaining his practice through word of mouth, Dr. Williams illustrated that healthcare innovation depends less on tools and more on people. Hiring for character and upskilling for operational needs is a concrete takeaway for any leader building or rebuilding a team. When the environment is unpredictable, as it often is in healthcare, adaptable people and strong relationships become your most reliable assets. Fourth, his reflection on risk and resilience highlight a principle often overlooked. Bold decisions rarely feel safe in the moment, but learning to expect challenges and trust your ability to respond can actually make uncertainty a little less daunting over time. For those considering a pivot or facing resource decisions, his journey suggests that curiosity and perseverance matter as much as any formal plan. What stood out to me most is the way Dr. Williams blends humility and creativity, not as a slogan, but as a day-to-day operating system. He shows that real innovation in healthcare isn't about chasing every new tool or trend. It's about asking what your community truly needs, learning from the setbacks, and trusting that small changes done with care and integrity can add up to something remarkable, right? So for everybody trying to find their way beyond the chart, that mindset is as practical as any playbook. Again, people first, listen deeply, and learn fast.